Hi folks, it's Dr. Sloan. We're going to talk about drugs for lipid disorders. All right, so these are some of the terms that you'll hear that are used to describe lipid problems. Lipid just means a fat. A lipid is a fat, okay? So hyperlipidemia refers to high levels of lipids in the blood, and that would be higher than normal levels. We do need lipids. We do need fats. You hear this all the time when you hear about good fats versus bad fats. But we do need fats, and they do play a very important role in function of our cell wall. They play an important function with our nerves. And so we don't want to, be totally without lipids. And so just wanted to clarify that hyperlipidemia means more than what you need for healthy body functioning. Hypercholesterolemia is high levels of cholesterol. Remember, emia is blood, and dys is bad. So dyslipidemia is abnormal levels of all lipoproteins or lipids. So the big problem with these high levels of fats is that it's asymptomatic. So no one's going to walk around and be like, oh, I ate too much fat today, unless they have GI issues, which is totally separate. This problem is asymptomatic, meaning that nobody knows that it's there, and it can be inherited versus acquired. So again, these lipids in the body are important. Triglycerides make up 90% of lipids in the body, and they fuel the body in times of need or an energy source. So think about saturated versus unsaturated fats, okay? So we have different kinds of triglycerides. We have HDLs and LDLs. We'll talk more about that coming up. Phospholipids, these are essential to building plasma membranes. So again, cells and walls. And then steroids, which sounds really weird. You're like, what? Steroids? What are we talking about? We're talking about the sterol nucleus, or the ring structure that is sort of the basis for the cholesterol molecule. And again, this is a natural and vital component of plasma membranes and plays a role in the development of atherosclerosis. I just want to be really clear here that we're not talking about steroids like steroid type drugs like corticosteroids. We're talking about sterol components, and this is linked, called steroids. It can be confusing, can't it? So cholesterol. Back in the day, eggs were evil. People said, oh, eggs have cholesterol. You can't have eggs because they would increase your cholesterol. But again, cholesterol in and of itself is not evil. Unlike triglycerides, which fuel energy, cholesterol is a building block for many biochemicals, critical ones that we need in our body. So it's a building block for vitamin D, for bile acids, which again help us with food digestion, with cortisol, which helps us with that fight or flight, with estrogen, progesterone, testosterone. It's essential for life. And because of that, our bodies, surprise, surprise, our bodies make a lot of things that we need. 75% comes from our body. Okay, it's manufactured in the liver, cholesterol is, but 25% comes from our diet. So this is a very common problem, high cholesterol. Again, we could call this dyslipidemia, but most Americans know this as high cholesterol, okay? 31 million Americans have high total cholesterol, but we are on the decrease, which must mean maybe we're doing something right. Maybe our discussions now about healthy eating and exercise and fruits and vegetables is starting to make a difference. It is making a difference in childhood obesity. And so it would make sense that it's making a difference here in cholesterol as well. Peak ages for high cholesterol is 45 to 54 in men and 55 to 64 in women. So for women, it takes about 10 years longer for them to end up having a cholesterol problem. Ethnic groups with the highest cholesterol are Mexican American men and Caucasian women. High cholesterol, the definition of high cholesterol is twice the risk, means that you have twice the risk of heart disease compared to those with optimal cholesterol levels. So if you have an elevated cholesterol, again, elevated above normal, then your risk for heart disease increases twofold. So total cholesterol needs to be less than 200. Your LDLs, and we'll talk about these, should be less than 100. Your HDLs should be greater than 60. And just remember my little saying that the low should be low and the high should be high. Serum triglycerides need to be less than 150. So those are 4 distinct types of lipids with 4 different tests that measure those particular components. So always lifestyle changes to decrease lipid levels should be tried first. Are you hearing a theme here? This is also what we recommend in mildly elevated blood pressure. So lifestyle changes really can make a difference. Per the American Heart Association guidelines on the management of blood cholesterol, your diet should be what we know a healthy diet to be. Low-fat dairy, low-fat poultry, fish, seafood and nuts, vegetables, fruits, whole grains, and legumes. Essentially a Mediterranean-type diet. Reduce saturated fats and increase soluble fiber. So increased soluble fiber usually comes from breads, it can come from beans, it can come from fruits and veggies. Weight control, physical activity, 3 to 4 sessions a week, 40 minutes per session. No smoking. Smoking really affects lipid levels, and then reducing alcohol consumption. So our prototypes for these, for treatment of dyslipidemia, there are 3. And these are by no means all of the drugs. These are just 3 big ones that tend to be used. So let's talk about atorvastatin first. Atorvastatin frequently will be called a statin drug. Now, there's rosuvastatin, there are other statins. So atorvastatin just happens to be our prototype. But again, if you learn it, it is, it can be pretty much applied across the board to all statins, the things that are characteristic of this drug. So this is better known as Lipitor. Right now, it's the second most commonly prescribed drug in the United States. It is a dyslipidemic or lipid-lowering medication. Its pharmacologic class is that it's an HMG CoA reductase inhibitor. And you're like, what the heck is that? Well, HMG CoA reductase is needed in the liver for the biosynthesis of cholesterol. So now you have a drug that can block this reductase, which again, because of its ACE ending, is an enzyme, right? HMG CoA reductase is an enzyme. So it can block the action of this enzyme, which then blocks the biosynthesis or creation of cholesterol. So it lowers LDL cholesterol, which is great, right? Because LDLs is our bad cholesterol. Remember, you want the lows to be low. So this drug helps the lows to get lower. It decreases triglycerides, which also tend to be elevated. and it increases our good cholesterol, which is high density lipoproteins, HDLs. And another way to think about this is high density lipoproteins are going to be better. Now, this is just an analogy, not truth. Better scrub brushes, right? If they're high density and they're hard when they go through the vessels, they're going to be better scrubbers of those atherosclerotic plaques. So it's just another way to think about it. If you have a LDL, I think of that more like almost like I don't know, like a sponge that's super squishy, and as it goes through, it's not really going to do much, versus HDL is like a scrubber. Okay. So again, just a way to remember things. So remember, bad cholesterol needs to go down. Good cholesterol needs to go up. This drug does both of those, and decreases triglycerides as well. I mean, this is like a home run hitter right here. The action only occurs while taking the meds. So you can't go on statins for a little while and then stop and expect the effect to continue on. It only works while you're taking it. So much, I'm sure, to the glee of many pharmaceutical companies, you have to stay on statins for life, which means you have to keep buying them every single month at the pharmacy. The benefits is that it slows the progression of coronary artery disease and reduces mortality from coronary artery disease. Pretty awesome drug. Okay, so, and just again, CAD, if you don't remember what that is, coronary artery disease. How is atorvastatin given? It's a pill. It should be given with food to reduce GI distress, but it really works well if you give it at night because your liver makes cholesterol at night. It's like the cholesterol factory works the night shift. So you want to give it right before the patient goes to bed and then let that drug do its thing during the night. It is a pregnancy category X, meaning it is teratogenic, which means it absolutely does cause birth defects or is harmful to the fetus, which means under no circumstances can a pregnant woman take atorvastatin. It is not okay. So if your patient is of childbearing age, this might be one of the things that you include in your patient teaching is this is a drug that can cause birth defects. And so while you're on it, you need to be avoiding pregnancy. And if and when you decide to get pregnant, you need to go off this drug, or you discover that you're pregnant, you definitely need to get off this drug. Side effects, headache, GI cramping, diarrhea, constipation. Again, it's messing with an enzyme that makes cholesterol in your liver. So this is kind of a normal thing that we would think about. And then in a very small number of patients, it can cause liver damage. So the very first few months that a patient's on the drug, we need to monitor their liver function tests. And that's all you need to know about it right now. We're not going to go into the specific tests, but liver function tests to make sure that these patients are responding well and not having any issues with it. And if after a few months the patients are doing fine, then we don't need to continue to monitor liver functions, only if we have a reason to suspect there might be a problem. Now, serious adverse effects. The big one for this drug is rhabdomyolysis, and this particular condition, which is basically the breakdown of muscles, you are at increased risk for this when you're taking this drug with a macrolide antibiotic. So for instance, like a Z-Pak or erythromycin, those are what we call macrolide antibiotics. So cyclosporin is another drug that when you take atorvastatin with cyclosporin, you are at higher risk for rhabdomyolysis. And then niacin, and I think this is really interesting because many people will use niacin. It's something you can buy over the counter, and they'll use it to try and control their cholesterol. And actually, a lot of studies have shown that niacin is not that helpful. But you may have a patient who's on niacin who's not told you about it, or you've not asked about things that they're taking that have not been prescribed by a physician. So remember, in that history, we want to know, what are you taking that's prescribed? What are you taking that you buy at the drugstore? What are you taking that you buy online? Supplements and other things. Because niacin may be one of them, and you need to know. This drug can also increase levels of digoxin. So if perchance your patient also is taking digoxin, we're probably going to need to monitor digoxin levels very, very carefully while you're on atorvastatin, if it's deemed appropriate for you to even be on this drug while taking dig. And then grapefruit juice, our best friend in pharmacology, inhibits metabolism of atorvastatin, so absolutely should not be taken drunk with this drug. Okay. Cholestyramine. Now, cholestyramine, I think it sounds like styrofoam. And so you can just keep that visual in your head if you want. But cholestyramine is also hyperlipidemic, but it works by collecting bile acid. It's almost like a sponge that soaks up bile acid. So think about that. You know what styrofoam looks like. What if styrofoam was actually going through your gut and sucking up bile acid, which has cholesterol in it? Okay. So it comes in a powder. You have to take it with at least 60 to 180 mils of water. And drink it immediately. So, and then here's the thing about cholestyramine, because it acts like a sponge and it gathers up all the bile acid, which is where the cholesterol is, once it's been excreted from the liver out into your intestines. Then you have to be careful about taking it with other drugs, because this drug can potentially also kind of suck up other drugs and just carry them right out of the body and not allow them to go into the bloodstream and do their intended job. So patients who are taking other medications need to either take the medications 2 hours before you take cholestyramine or 4 hours after you consume cholestyramine. Because cholestyramine, again, is going to act like a sponge, suck up those bile acids, and just continue to carry all of that right out of the intestine, right out through fecal material. Okay. And then again, taking with food could impair absorption of nutrients and minerals, because again, this acts like a sponge. So just think about this medicine as styrofoam. That is a styrofoam sponge that's soaking up cholesterol that's inside the bile acids, and then it's going to soak up whatever's around it too, whether that's nutrients or another drug. And so there needs to be a big window on either side of taking this medication before you can take other drugs. And then side effects, this totally makes sense. If you think about this, you have a sponge going through your stomach that's full of bile acids. You may have gas, bloating, constipation, nausea. So pretty straightforward drug, kind of almost a sort of a functional drug that, doesn't have this really elegant blocking mechanism or whatever. It just sort of soaks up the bile acids. So again, cholestyramine binds with bile acids, which are a metabolite, meaning they're like a byproduct of cholesterol production, and that's excreted in the feces. And so it's taking this cholesterol out. It's taking out LDL cholesterol, which is kind of interesting. And because it's taking out LDL cholesterol from the body, the liver responds by making more LDL receptors But again, that's LDL receptors in the liver. So then LDL can sit in the liver and not out in the blood where it's causing problems. So I hope that makes sense. We talked about that a little bit in class. Don't worry about this. This isn't going to be a piece or something that you'll see on an exam, but it is how cholestyramine works to reduce cholesterol. Anyway, it can produce a 20% drop in LDL cholesterol. And remember, we want our lows to be low because this is the bad cholesterol. Last but not least, we're going to talk about gemfibrozil. Gemfibrozil is also an anti-hyperlipidemic. It is a fibric acid drug. So we don't really know exactly how this drug works, except that we know that it increases the breakdown of lipoprotein lipase, which increases breakdown and elimination of triglycerides. So gemfibrozil is for triglycerides. Okay, so it can reduce very low density lipoproteins by 50% and increase HDL. It may increase the likelihood of gallstones. It may affect liver function. So people who have hepatic impairment should not use this drug. Again, it's an action that can affect the liver. It may increase the effect of anticoagulant medications. Well, that could be kind of scary. If anticoagulants are already doing their job, patients are at risk for bleeding. This increases the effect of anticoagulant medications, then the patient is even more risk or higher risk for bleeding. There's an increased risk of myopathy and rhabdomyolysis with statins. So here is another drug that when taken with statins could cause rhabdomyolysis. So probably ought to pick one or the other. And then side effects, again, all GI, nausea, diarrhea, abdominal pain, dyspepsia. So I hope this helps a little bit with drugs for dyslipidemia. And remember, number one thing we're going to try is lifestyle changes. And then if we don't get the effect we need, we're going to go on to these drugs. These drugs are widely used and actually probably responsible for preventing a lot of the heart disease that we might see without their use. Okay, that's it.